Okay, I want to welcome everybody back from the break and start the afternoon session of the meeting. The first thing is we're going to have a presentation on challenges and opportunities in air filtration intervention studies. And to do that, I want to introduce Ryan Allen. He's a professor in the Faculty of Health Sciences at Simon Fraser University in Vancouver, Canada. His research program bridges air pollution exposure assessment and epidemiology with interests in the evaluation of interventions to reduce air pollution-related health effects and the impacts of air pollution exposure in early life on growth and development. He'll be discussing the challenges and opportunities offered by air filtration intervention studies. Thanks, Ryan.
Great, thanks for the introduction and for the invitation to participate in this meeting. So I was asked to talk about kind of our research group's experiences conducting air filtration intervention studies over the last 10 years or so. So this really isn't a biomonitoring talk. I'll mention biomarkers very briefly, and we've used biomarkers of exposure and of effect in our studies. But this really isn't a biomonitoring talk. It's really just a kind of a show and tell of our experiences, including some things that worked and some things that didn't. And I want to make clear that this is not, I don't claim that we're the experts on doing these studies or that we've, figured it all out. The idea here is just to not so much tell researchers what they should do, but just give researchers some thoughts on things maybe to consider if you were going to do one of these studies. Certainly things I would consider if I were to do another one of these studies. So to start, I'll just disclose that for the most recent study, which I'll tell you about, we received some in-kind support in the form of discounted air purifiers from Koei, who's a Korean manufacturer, but they had no role in any of the research that we've conducted. And I'll also just make clear that this presentation is not meant to be an endorsement of any air cleaner manufacturer model, so I'm not trying to sell you air cleaners. So the three studies that I'm going to draw from in describing our experiences all used portable HEPA filter air cleaners to try to understand relationships between air pollution and health. The first study was conducted in a small town in Western Canada, in British Columbia, and that was focused on wood smoke and cardiovascular outcomes. The second study was conducted, was a very similar study in many ways, was conducted in Vancouver. And the third study, which is actually still ongoing, is a longer term study actually in Ulaanbaatar, the capital city of Mongolia, focused on, that's a city that's impacted heavily by coal smoke. And the goals of that study were to look at fetal growth and early childhood development as health outcomes. So I've structured this talk as a kind of a list of 6 considerations or groups of considerations, as I said, that I would kind of recommend thinking about if you're going to design and conduct one of these studies. And this is not kind of a typical research talk. I'm really focusing on the methods and our experiences, and I won't say a whole lot about results, but I'll mention results in a few cases when they're relevant to one of the considerations that I'm describing. So the first study that we conducted used a randomized crossover design. So each participant underwent 2 weeks or 2 7-day periods of air pollution monitoring. And at the end of each 7-day period, we made measures of markers of health, sort of cardiovascular related health outcomes, including some measures of oxidative stress, inflammation, and endothelial function, things we've already heard quite a lot about today. And during one of the sessions, the HEPA filter was operating normally. During the other session, the HEPA filter was operating, but the filter was actually removed. So it's sort of what we call placebo or sham filtration. And importantly, the order of filtration and sham filtration was randomly assigned. And this was a group of relatively healthy, kind of middle-aged adults, and we measured exposures including PM2.5 and levoglucosan, which is a marker of wood smoke, both inside and outside of homes. The second study was very similar to the first. This one was conducted in Vancouver, same study design, many of the same outcomes, many of the same exposure measures. The key difference here was that we used some modeling work that had previously been done in Greater Vancouver to identify neighborhoods and areas of the city that were impacted by one but not both of the pollution sources of interest. And those were traffic-related air pollution, trap, and wood smoke. And so you can see in the map, the areas in red are postal codes that are have relatively high traffic-related air pollution concentrations and relatively low wood smoke, and then the areas in green are the reverse of that. And then the third study that I'm going to draw from is the one that we're actually still working on, and this was a very different study in many ways. Rather than using that randomized crossover design, this was a parallel group randomized control trial, very much like a drug trial or a vaccine trial. We enrolled a group of non-smoking pregnant women living in the capital city of Mongolia, and we randomly allocated them into either an intervention or a control group, where the intervention group received the air cleaners, the control group did not. They used them from enrollment in the study until the end of their pregnancy. The study was initially designed to look at birth weight as a measure of fetal growth. And then we subsequently got funding to continue to follow these kids and look at indicators of early childhood development, things like cognitive performance, behavior, measures of obesity, measures of respiratory symptoms, those kinds of things. And like John said in his work in Fresno, we actually have money to continue to follow this cohort, but COVID has obviously made things a little more challenging. So I guess the first consideration when you're thinking about one of these studies is how do your plans fit in with what's already been done and what we already know? And I would say that this kind of landscape has changed a lot over the 10 years since we started doing these studies. That first study was published in 2011, and at that time there was some evidence that air cleaners, portable air cleaners, improved, reduced particulate matter concentrations, particularly in residences. But over the last 10 years, there's been quite a lot of research in this area, to the point that we're now getting some review papers, and I've included some screenshots here of different review papers, kind of summarizing this literature. I would say now there's pretty strong evidence that these devices reduce PM concentrations in residences, as well as some evidence that these devices or enhanced filtration in HVAC systems can reduce concentrations in public buildings like schools. These are mostly short-term studies, not entirely, but most of them are short-term studies looking at kind of days or weeks. And there is now some evidence of health benefits from filtration, but there's less health evidence than evidence of exposure benefits. And then sort of once you've situated the proposed study in kind of what we know and what we don't know, I guess the next sort of consideration is what is the goal? And what I mean by that is the goal to actually evaluate the intervention because you're interested in the intervention, or is the intervention simply being used as a research tool to reduce exposure and introduce an exposure gradient? So since we've started doing this work in Mongolia, and I've given talks about it, and I've had people sort of ask, do you think air cleaners are the solution? And my answer is always, well, no, air cleaners aren't the solution to air pollution. The solution to air pollution is to produce less air pollution in the first place. So these air cleaners might be useful in particular settings for particular populations. But really my interest in these studies with these air cleaners is that they allow us to ask the question, what happens to health when air pollution goes down, when air quality improves? And so I think it's worth, as you're thinking about these studies, it's worth thinking about whether you're interested in the intervention per se, or whether you're just simply interested in exposure reductions, and air cleaners are one way to kind of manufacture an exposure reduction in your study. There are a lot of advantages to these kind of studies, as most of you probably know. Certainly by randomizing exposure in some way, we reduce the potential for confounding bias, which is always a challenge in these kind of studies. We can enhance or increase that exposure gradient, and that's where a lot of the statistical power in these studies comes from. The more kind of the larger the difference in exposure within your study population, the more likely you are to see associations with health. And one of the things I really like about these studies is that they're fairly intuitive. So to try to describe a case control study to someone who isn't trained in this area can be challenging, but there's sort of an intuitive element to the idea that you have health measures when air filters are used and health measures when air filters aren't used, and you're comparing those. So that can be useful for trying to kind of communicate and disseminate your results. Of course, disadvantages, these are difficult studies to do. They take a lot of effort, and as a result, we typically have relatively small study populations. There are concerns about external validity, that is, people who participate in these studies may differ in important ways from people who don't participate in these studies. Another sort of exposure-related challenge with these studies is one that I'll describe next, and that is this idea that in these studies, when you evaluate the health benefits of the intervention, you're effectively using intervention status, that is intervention versus control, as a surrogate for exposure. You're kind of using a binary surrogate in place of a continuous exposure. And I'll use some results from our studies to try to illustrate this point. So in the Mongolia work, we measured PM2.5 inside residences at 2 points in each woman's pregnancy, right after enrollment and then a few months later in pregnancy. And so we had these kind of two discrete measurements of pollution concentration, and we wanted to try to model what was happening in all the other weeks of pregnancy. And so we looked at predictors like outdoor pollution concentrations and whether there was smoking in the home and window opening and season and various things. And we were able to develop a pretty good model for explaining or for predicting pollution concentrations. The model explained about 80% of the variability, but intervention status alone only explained about 6% of the variation in pollution concentrations. So the situation in these intervention studies, even though these interventions are effective, these air filters are effective, the exposure distributions of your groups don't really look like this, what I'm showing here. They look more like this figure on the right, where you have these exposure distributions and the intervention is shifting the distribution down because the air cleaners do work, they do reduce concentrations, but there are a lot of sources of variability in your population that will have nothing to do with the air cleaner. And so you're essentially using a fairly crude indicator of exposure when your analysis focuses on intervention versus control. And as the reason I'm kind of going on and on about this is that we've seen what we think are the effects of this. So this figure shows results from our Vancouver study, where we're looking at associations between various measures of exposure and C-reactive protein as an indicator of systemic inflammation. And you can see that for HEPA filter status or intervention status, intervention versus control, we really saw no evidence of associations. Whereas for PM2.5, we saw some evidence that when PM2.5 went up, C-reactive protein went up. And one explanation for this is this idea that air cleaner status, intervention control, is really introducing a lot of exposure misclassification. And so one approach might be, when you're doing these studies, is to think about analyzing exposure both ways. You can look at whether the intervention is beneficial using kind of a binary approach, or you can actually look at measures of exposure, which may give you a more refined exposure estimate. Excuse me. Another consideration here, and this actually came up a little bit in the discussion earlier, is the idea that these air cleaners are only doing any good in terms of exposure when the participants are in the location where the air is being filtered. And we didn't measure personal exposure in our studies, but other studies have demonstrated this very clearly. For example, there was a study in Beijing that found that HEPA filtration reduced concentrations in homes by 82%, but personal exposures were actually a bit higher when the filters were on. The filters did essentially no good for personal exposure, and the authors attributed this to time spent in other settings. Similar results from a study in Shanghai, where the reduction in concentration was about 68%, but the reduction in personal exposure was only about 27%. And obviously this will depend on how much time people are spending away from home. But for age groups and populations that do spend a significant amount of time away from the environment that is being filtered, this can be an important consideration. And then a third exposure-related consideration that I would highlight is the importance of the baseline concentrations. So the exposure gradient that you get in your study, which really drives a lot of your statistical power, comes really from two things. It comes from how effective the air cleaners are, but it also comes from what the baseline concentration is. This is probably obvious to most of you, but I just wanted to emphasize it. So in our study, number one, we saw about a 60% reduction in mean PM2.5 concentrations when the air filters were on, and that corresponded to about a 6.5 microgram per cubic meter contrast in PM2.5. Study 2, the air cleaners were less effective and the baseline levels were lower, so there was a much smaller exposure gradient. And then in study 3, we saw about a 30% reduction, which corresponded to about a 7 microgram per cubic meter contrast between the intervention and the control group. And so study 3 is a useful example. The air cleaners, for various reasons, weren't as effective, but because we conducted that study in a place with high baseline concentrations, that 29% reduction still corresponded to a relatively large contrast and exposure. And this again has implications for how much power you have to detect associations with health. Study design is obviously an important consideration. As I said, we've relied largely on this randomized crossover design, which is a very useful design because effectively participants serve as their own controls. You're basically comparing each individual to him or herself. And by randomizing the treatment order, with some people getting the real filtration first and others getting the placebo filtration first, you reduce the potential for confounding by things that are varying in time. One of the things we have had to sort of puzzle with when we do these studies is whether or not to include a washout period. So often in these studies, there'll be a gap between session 1 and session 2 that is meant to prevent any effects from session 1 from bleeding into or sort of carrying over and contaminating session 2, so to speak. And there was a review paper published just a few weeks ago that looked at these studies, and they really highlighted the lack of these washout periods as an important limitation, including in some of our studies. We have not used washout periods in our studies, and I would argue that that criticism is maybe a little bit overblown. And the reason we've not used washout periods in our studies is that we thought that the exposure-response relationship for the outcomes we were looking at was relatively short compared to the duration of the monitoring sessions. So for example, we thought that it was probably only about the 48 hours or so of exposure prior to the health measurements that was really driving those measurements. As a result, with 7-day monitoring sessions, we thought that the first sort of half of the monitoring session was effectively acting like a washout period. So I would argue that the need for a washout period probably depends on the time scale of that exposure-response relationship relative to the duration of the monitoring sessions or the duration of the intervention. I mentioned, that we'd focused on healthy populations in our studies. And I'm kind of oversimplifying here, talking about healthy people versus susceptible people. When I say susceptible individuals, I mean, for example, maybe people with asthma or some other morbidity that may make them more susceptible to the health effects of air pollution. And there may be valid reasons for focusing on one or the other. For example, susceptible individuals may be more responsive to air pollution. You may be more likely to see a response in that group, whereas healthy individuals may allow for a simpler analysis. So for example, they may be on fewer medications that may mask the effects of air pollution. But these studies tend to be pretty small, and often you're not able to look at sort of a bunch of subgroups. You're kind of end up analyzing the cohort as a whole. And so the approach that we've taken is that because of the way our studies were conducted and the places our studies were conducted, we thought it was going to be difficult to recruit a sufficient number of susceptible individuals to make for a meaningful analysis. And so we were worried that having just a few susceptible individuals would make the analysis more complicated and more challenging. And so we sort of took an all or nothing approach. The idea being, if you can't get enough susceptible individuals into your study population to do a meaningful analysis on that group, it's best to try to actually not enroll those people into your study. And so that's why we ended up with these cohorts where we intentionally try to recruit healthy individuals. And that's not to suggest that's the only approach, but and it won't be appropriate or feasible in every situation, but it seemed to be the right approach for us. As far as the air cleaners go, the first decision is obviously, or maybe not obviously, but one of the first decisions is whether you're going to do filtration in the HVAC system or use portable units, or both, as is the case in the proposed schools study. There is this concern that I think was mentioned earlier about the use of really high efficiency filters in older HVAC systems where the system may not be able to handle that high level of filtration. And I'm not an expert on HVAC systems, but you hear this kind of anecdotally sometimes. In our studies, as I said, we used portable air cleaners. We used HEPA filter air cleaners, but there are other technologies available, for example, electrostatic precipitators. A really important consideration, of course, is the amount of filtration that you're achieving relative to the volume of air that needs to be filtered, to the size of the room or the building where you're conducting your study. And that's a function of having either the right size air cleaners or the right number of air cleaners, operating them on a high enough fan setting to do the job. But all of those things have implications for noise. And then you can think about compliance monitoring, trying to determine how much your participants are actually using these devices. That could be done via self-report, using some built-in timer, or using some external measure of electricity, for example, external measure of compliance, like measuring how much electricity the unit is using. And then converting that into a measure of air cleaner use and intensity. I'm gonna skip over some of the more nitty-gritty details of what we've done with the air cleaners in our studies. I'm happy to tell folks about that if there's interest. But I mentioned noise. I just want to highlight this as an important issue. So these are results from our Mongolia study showing concentrations in intervention and control groups after the air cleaners were first deployed, and then after about 5 months of use. And you can see when the air cleaners were first deployed, they were pretty effective. They reduced PM 2.5 concentrations by about 40%. After 5 months of use, the effectiveness had dropped to about 15%. And there are a few reasons that we think that happened, but one of them, again, this is sort of anecdotal, but one of them is that we heard from a number of participants that they were concerned about the noise, particularly in the bedroom units. And so they would just turn the unit off. That sort of level of annoyance with the noise kind of increased over time. And so this noise issue, I think, becomes very important in these studies. The air cleaner is obviously doing no good if participants are turning it off. So I think it's really important to try to select air cleaners that work and are appropriately sized, but are also not so noisy that they're going to drive participants crazy and make them turn off the air cleaners. I just want to say a few words about kind of how we've selected outcomes, not so much which outcomes we've selected, but our sort of how we've thought about selecting outcomes. And John highlighted this. This earlier. This is a very complicated figure showing kind of the different pathways through which air pollution can ultimately affect cardiovascular health in this case. And the details aren't important for the point I'm trying to make here, which is just that I tend to think of these as kind of a chain of events. This happens, then this happens, then this happens, then this happens. And I think of that chain as moving from sort of indicators of mechanism all the way ultimately to some disease or some clinically relevant outcome, like maybe it's a heart attack or a stroke. And this is a little bit sort of simplified, but you can sort of think of this chain of events. And so the way that we've thought about outcomes is to think about kind of where in this chain of events we want to be when we're doing our study, and the trade-offs involved in being at different parts of this chain. So for example, as you move further to the left in this figure, you may have measures that are more sensitive to air pollution, more temporally variable, but also probably less clinically relevant and potentially more difficult to interpret and to communicate. Whereas as you move to the right, you sort of trade off some of those considerations. And so we're less interested in kind of the mechanisms of how air pollution has its effects. And so our focus was really on what we call intermediate outcomes, outcomes that are that are changing on a time scale that we can measure, but that are also predictive of more clinically relevant outcomes. So this is just sort of how we've thought about how these outcomes fit together and how to select one way that you might select outcomes in your study. So just to summarize, I've been over the last several years a real proponent of these intervention studies for a number of reasons. I think they provide several advantages beyond just the one you typically hear, which is that they minimize confounding bias. You can use them to actually evaluate the benefits of air cleaners, or the air cleaners can simply be a tool to introduce an exposure gradient, which can be useful to study. You get a lot of statistical power in these studies, or you can, if you have a sufficiently high baseline pollution concentration and if the air pollution effectiveness is sufficiently high. It's probably obvious to all of you, but you really need to carefully consider the size, number, location of the air cleaners and the amount of noise that they produce. And of course, I just wanted to kind of finish by making the point that this is not meant to be kind of a comprehensive list of considerations. There are a lot of things I didn't talk about, including the ethical implications of these studies, issues around participant burden, which you all obviously know about, having done a lot of biomonitoring work. And then a lot of analysis considerations. So for example, in these studies, you're going to have a lot of missing data typically, and how are you going to handle that in the analysis phase. So with that, I'll just acknowledge that the work that we've done that I talked about today was funded by the Canadian Institutes of Health Research, and there were a lot of people involved at a lot of different institutions, too many for me to name. And I've included here for your in case it's of interest, I've included all of the references for the studies that I mentioned. So with that, I will finish up, and thanks for your attention, and I'm happy to chat or try to answer any questions.
Thanks so much, Ryan. I really appreciate that. You elucidated for me some of the advantages that I hadn't, or anyway, some of all of the situations around these kinds of intervention studies that are helpful here. We have 15 minutes now for questions and discussion from both panel and audience. So a heads up to participants and public who would like to ask questions or provide comments. You can do that by email or through the GoToWebinar, and I'll open it up to panelists who have questions. Tom.
Hi, thanks. That was really interesting. I think it's very useful to do these studies. I guess the question, I just was interested in a little more information about compliance. I mean, you talked about compliance as an issue in Ulaanbaatar, or Batur, and but in the British Columbia studies, in the chart, as I recall, it said the compliance, the devices were not preset, so they could control the fan speed, and the fan speed, of course, is really important in the amount of air volume that's clean. Did you have some opportunities to look at compliance in those studies and how it affected results, where it was kind of open to the individuals how much they turned up the volume?
Yeah. I kind of glossed over that very quickly. We didn't really do much with compliance in the two studies in British Columbia. We never really settled on a method of measuring compliance that we were very happy with. And you mentioned that we didn't do really anything in terms of trying to control how people used it. We basically asked them, when the study started, we asked them to use the air cleaner at the highest setting that they were comfortable with, but obviously that will vary from person to person. And so that is a source of variability in the study, with some people using it on high and some people using it on low. And that's part what we were trying to address in the Mongolia study. So I mentioned that we bought the air purifiers from the manufacturer, and when we did, we actually had the manufacturer lock the air cleaner on a particular setting. So it would only operate on one setting. You couldn't, it was either on or it was off, but there was no adjusting the fan. In hindsight, that was probably a mistake. And the reason is, letting the participants turn it up and down has its own set of problems, but at least if they're worried about the noise, for example, they can turn it down. In Mongolia, what happened is they were concerned about the noise and they couldn't turn it down, so they just turned it off. So having done it both ways, I would probably, my sense is that the way we did it in the first two studies was probably better. It wasn't perfect, but it was better, because then at least it's better that they use it on low than that they don't use it at all. But no, we don't have any really good data on how those turning it up and down, how that influenced our results. We didn't really have much in terms of compliance monitoring in those first two studies.
Thank you.
Jenny.
I thank you for that really thoughtful description of pluses and minuses of different approaches. I just have a vague memory of a study that was done in Las Vegas looking at black carbon inside and out in schools, and air filtration intervention that was performed. And I just remember reading it, and they just remarked that they had this whole system of air cleaning, but it was completely foiled by the teacher propping the door open. And I'm just wondering how much, like, people opening doors, or what instructions, what's your experience with instructions about doors and windows open or not, and how that might affect results?
It has a huge effect, because it essentially, when you open the door, open the window, you're dramatically increasing the amount of polluted air that needs to be filtered, right? And so it has a huge effect. I didn't show it because I couldn't show you everything, but in Mongolia we looked at filter effectiveness by season, and the effectiveness in the summer was basically zero. And we think that's for two reasons. One is pollution there is very seasonal, and then in the summer pollution levels are lower, and so people are just less worried about it. And so we think they use the air cleaners a bit less in the summer because they just weren't as worried about it. But the real driver, we think, is that people were opening the windows all the time. Nobody there has air conditioning, so when it gets hot, you just open your windows, and the air cleaner just can't keep up. So that's a hugely important factor. You can basically make the effectiveness go to zero if you open enough windows.
Thank you.
Other questions or comments for Ryan? Shobha, I want to check in about other comments or questions that are from anyone other than the panelists.
Yeah, thanks. I see none at this time.
Okay, great. Jenny has a question, and then I have one after that. Go ahead, Jenny.
You should go ahead with yours.
I appreciated your slide showing the range of looking at sort of indicators of mechanism versus health outcomes and the pluses and minuses of each. And I wondered, given that the intervention study that Biomonitoring California is contemplating, where we're really looking at the design is to look at biomarkers of exposure, really more than biomarkers of effect, and whether you have any input for the program, given some of the liabilities of the biomarkers that are at that end of the continuum. If you have any recommendations or suggestions relevant to this study that they're working on.
I have to admit, I don't have a lot of experience with biomarkers of exposure. We in our studies to measure exposure, we have kind of done it the old-fashioned way, so to speak, which is to measure, what's in the air inside people's homes and outside of people's homes. So I don't have a lot of experience with biomarkers of exposure. I will say some of the biomarkers that are being proposed in that study, I would argue are probably more effect biomarkers than exposure biomarkers. Certainly the PAHs and that sort of thing are obviously exposure markers, but there was some talk of sort of inflammatory markers and those sorts of things. And I think trying to use those as biomarkers of exposure is going to be really difficult to interpret because they're so non-specific, right? There are lots of things that cause inflammation. There are lots of things that cause oxidative stress. And so trying to interpret those as telling you about exposure, I think may be a little bit challenging. I guess the line between a biomarker of exposure and a biomarker effect starts to get a little bit fuzzy. But that's really the only comment that I would make, is that some of those, I think, the interpretation may become difficult, again, just because they're so non-specific. But as I said, take all this with a grain of salt, because I have much less experience with biomarkers of exposure. We've done some work in our studies with metals, for example. We've looked at cadmium and lead and mercury and those kinds of things. But again, my experience with those biomarkers is fairly limited.
Thank you. And I think part of the question is how that's being framed in results return, because participants tend to just lean so much toward wanting to hear and therefore hearing conclusions about health impact that maybe that's part of the balance. But Sarah, it looks like you have something to add here.
Yeah, I just wanted to thank you, Meg, for raising that, and note that that's actually one of the challenges we listed, and also a particular discussion question we want to go into. But I did want to clarify that, yes, it's true, we're planning to use them as biomarkers of exposure, in part because of all the past SGP input about, this is an exposure program, our goals are about exposure. It doesn't really seem feasible to me and others, my colleagues, to provide a health interpretation of those biomarkers. And in fact, we're really using them as complementary. So we were very aware that even just trying to use PAHs and VOCs, there's a lot of difficulty interpreting those. So based on all the research that Susan, Stephanie, and Julia did, we're kind of going at it with multiple lines of evidence, including air measurements, biomarkers of exposure, and biomarkers of effect, although we're using them as another form of biomarkers of exposure. So really the idea is to give us a nice suite of information to try to interpret our results the best as we can. But we're very aware of the challenges in what we're trying to do, and we definitely appreciate any ideas on how to do that better.
Jenny, you had a thought.
I just had a question, because I assume that your participants in Mongolia were possibly lower income than in Vancouver, and because we were working with some homes and schools in Tijuana, and I was kind of wondering about trying to raise money for getting air cleaners, and wondering if participants would think the electricity required to keep them running would be a burden. And I'm just wondering how that came up. Did you pay for the electricity in Mongolia, or did they pay for it? And did they complain, or how did that go down?
Yeah, it's a good question. Certainly in kind of a global context, our cohort in Mongolia was relatively low income. But in the Mongolian context, they were actually quite wealthy. This is an urban apartment dwelling population. But yeah, so participants received an honorarium for participating. And part of the intention of the honorarium was to offset electricity costs. So we didn't pay the electricity per se, but they received an honorarium that was sort of intended to cover that. And we did hear, again, it was anecdotal, but I mentioned complaints about the noise. The other reason that we heard that participants turned off the air cleaner or used it less was exactly that. It was concern about the electricity costs. So yeah, we heard that from a number of participants.
I think that is the end of our time, and I really want to thank you, Ryan, both for the thoughtful presentation and sticking around to respond to questions, and we'll also look forward to your contributions to the afternoon discussion. And with that, I want to move on to our next speaker and introduce Maggie Clark, who is an associate professor in the Department of Environmental and Radiological Health Sciences at Colorado State University. Maggie's research has focused on the health effects of exposure to air pollution, primarily from cooking-related biomass burning and from secondhand smoke, identifying and interpreting appropriate measures of exposure and indicators of future disease risk, as well as elucidating factors that may confer increased susceptibility to the adverse effects of air pollution exposures. She's committed to conducting studies within a community-engaged framework, and she will discuss for us issues around study design, including timing the measurement of biomarkers of exposure and effect in relation to air pollution intervention research. Thank you so much, Maggie.
Thank you, Meg. I also want to take the opportunity to thank Sarah and Susan and Stephanie for the invitation to speak with you all today. It's been enlightening to see how this process works in California. I'll also start by saying I have no conflict of interest to declare. So for a quick outline, I'll start my presentation by talking a bit about the general perspective about how we approach choosing biomarkers. And these are primarily being conducted within an environmental health focused framework for research. As Meg mentioned, most of my research has focused on the impacts of household air pollution globally, which I may use the HAP acronym, and I know that stands for a couple other things as well, but when I use it, I'm referring to household air pollution, and I'll describe that in a little more detail. And I'll specifically use the example of the HAPPEN randomized controlled trial, and HAPPEN stands for Household Air Pollution Intervention Network, as an example of a study that has used a lot of biomarkers. In fact, it represents the study that has the largest set of biomarkers in a household air pollution study to date. We're targeting both biomarkers of exposure and effect in 3 distinct study population groups. So we're evaluating pregnant women, and then once the child is born, we're evaluating the children from birth to 1 year of age. And then we're also studying women that live in the same houses. We refer to them as older adult women that are 40 years and older. And so given these features of this study, I hope this example will provide a nice opportunity to discuss some of the design decisions that we made in that study that might apply to the California Biomonitoring study as well. So I'll end my part briefly, my part of the presentation by briefly going over some study design considerations, again, placed more in sort of a general environmental health research context. So in our studies, for the most part, we've tended to simplify sort of this quest for choosing appropriate biomarkers, again, within an environmental health context, into these 3 questions I have on the slide. So when thinking about biomarkers of effect, how informative is the marker regarding disease prediction? I'll talk a bit more about this in the next slide, but I will say that there are plenty of times when I think understanding more about the mechanism of action is the goal of research, but today I'm going to focus more on instances when biomarker discovery is not the primary goal of the study. The second point here is how stable is the marker as it relates to the hypothesized time course of the modifiable effect. And this is something that Ryan talked quite a bit about in his talk as well. In other words, does what we know about a particular biomarker's ability to change within a person line up with how long we've designed our study to last? And are we targeting the appropriate windows? So the first window being kind of this how long does a participant need to be exposed, or alternatively, in a lot of the cases we're talking about today, how long does that exposure need to be removed or reduced in order to see an observable impact? And the second window considers how long it might take for the biomarker to change. So sort of once this process is sort of set in motion, how long does it take for that biomarker response to be observable? So this is the case where there might be a latent period to consider. All of this is to say is that often our goal really is to say that if there is a true impact of the exposure on the proposed biomarker, that we've designed our study in a way that will be able to capture that. I'll also mention that gaining an understanding from the within and between person variability is really important for sample size consideration as well. And I know Ryan discussed that during his talk as well. And so I think that's complementary with what I'd like to talk about a bit today. The third point here is about the feasibility of measuring a biomarker in a study setting. And so of course that really depends on the type of study that we're talking about. For a lot of the work I do in household air pollution studies that often occur in rural areas and low and middle income resource settings, it's a big challenge that we have to consider. It's likely not as big of a challenge in in a school setting in California, although it is still a challenge, I'm sure. But because of that reason, I won't be spending too much time on that third issue, sorry. So this probably also looks a bit familiar to what Ryan showed earlier, and I have a feeling I could say that a lot during my presentation, Ryan. But so there are various iterations of this figure that have been used to sort of conceptualize the idea of understanding biomarkers and research. And you can see the progression from exposure, often a measure of a pollutant that's external to the participant, to then internal dose, which can be estimated by using things like body size and breathing rates in conjunction with the external exposure, but for which biomarkers of exposure have become quite useful, and on to various stages of biomarkers of effect before actually reaching this onset of clinical disease. So this particular iteration was adapted from a version that the National Research Council had published in the late 80s, but I like this one because DiCaprio adds this top portion here, where in essence, he incorporated this idea that I think is used much more commonly now with the exposomics field of this sort of meet in the middle concept. So for exposomics and for a lot of the non-targeted research that's being conducted, the concept is that you study exposure and then you see, in the non-targeted world, what shows up as being associated with the exposure, and then you sort of do the opposite, where you have disease and non-disease people, and you kind of go backwards and say, well, here are these non-targeted biomarkers that show up as interesting, and so where is the overlap, and should we be pursuing that mechanism in more of a targeted approach? So I do think it also applies in the more targeted realm, which I'll be talking about more today, and for which the California Biomonitoring study is using. And really, I think the basis for applying this type of figure to what we do is the fact that we very rarely can design a study in the chronic health effects world that actually answers the full picture here, all the way from exposure to clinical disease. We would need much more time and money than what we're typically given, and even if we have a 5-year study design. So if we are interested in biomarkers of effect, we can shorten the time frame of our environmental health studies by gleaning knowledge from some of the more clinical epi literature that's out there, some of those long-term studies that have helped us to define this second arrow here. And so we may know a bit before we conduct our studies about what might be good, well-accepted predictors of the clinical disease that we're interested in. So if we're able to select, one or a handful of those biomarkers that are commonly accepted as predictors of disease risk, then we can focus on this first arrow here when designing our study. So linking the exposure with those biomarkers then allows us to characterize this association of interest, which really allows us to say something about the likelihood that the exposure will lead to increased risk for some clinical disease in a much shorter time frame than what we would need if we had to study the entire picture. Again, this is a point where participant burden comes into play here as well, especially when some of the clinical diseases might not be readily reported for something like a secondary data analysis. So I'll shift focus a little bit now to talk about that household air pollution intervention network study as an example of some of the biomarker work I've been doing. It's a randomized controlled trial of free liquefied petroleum gas fuel, including the stove, for 18 months, and I'll dig into those details a little bit in following slides. But the trial, which is still ongoing, is among 800 households in each of these 4 study locations across the globe. I'm not going to go into much justification for the trial itself, but I did want to point out that our protocol papers, one for the main trial, one for the exposure assessment, one for the biomarker approach, have been published in Environmental Health Perspective. So I encourage you to take a look at that if you're interested in some of the justification behind the reason we're conducting household air pollution clean or cleaner fuel interventions. So as I mentioned, the intervention is a locally available LPG stove having at least 2 burners. We provided the continuous free supply of the gas for 18 months. These photos here show 2 examples of traditional stoves, one from India and one from Peru. All households had to be using solid fuel burning stoves as their primary stove to be eligible for the trial, along with a few other eligibility criteria that I'll get into. The 2 photos here on the bottom show examples of the LPG stoves in households that were randomized to the intervention arm, and both of these also depict the educational and promotional materials that we use to encourage the safe and exclusive use of LPG. So in Guatemala, there were calendars provided along with some of the behavioral messaging, and then in Rwanda, there were posters. Our primary aims were to determine the effect of the LPG stove and fuel intervention on health in the 4 LMIC settings. The second aim was to establish an exposure response curve for all of the primary and secondary outcomes. And then thirdly, the one I'll focus on today, the objective was to determine the relationship between LPG intervention and biomarkers of both exposure and health. And I'll describe a bit more about the overall study design here, but as I mentioned, I will be focusing more on the biomarker aim towards the end of my time. So as I mentioned earlier, there were 800 households in each of the 4 country locations. The primary trial endpoints involved outcomes in the children for which we hypothesized that in utero exposure would be relevant. And so the goal was actually to recruit women and randomize them between 9 and 20 weeks of gestation. We then also followed the child from birth to age 1 year. And then in about 15% of the households, there was this older adult woman population, which was nice because it gave us the opportunity to ask questions related to chronic diseases, even though it's a much smaller sample size. But this was important for the biomarker of effect design as well. So I don't plan to walk through this entire table, but this is the table 1 from the main trial protocol paper. So please check it out if you're interested. in kind of understanding the full gamut of measures that we collected in the study. For this presentation purpose, I just want to point to the scale of the project, first of all, and then point out that there were at least 7 visits over the course of the 18 months with measures collected among the pregnant woman, the child, and the older adult women. So I'll come back to this a little bit more with a more specific focus on the biomarkers in a few slides. Again, without going into too much detail, I wanted to provide the study timeline as a reference to give you a sense of how we've moved through each phase of the study, from planning and piloting all the way to analysis and dissemination. Of note is that even once COVID-19 lockdowns or COVID-19 related lockdowns started to happen around the world, we were able to continue delivery of the fuel. And so the intervention was pretty much unaffected, fortunately. As you can see here, we anticipate unblinding here after the last child, the youngest child born, turns 1. And so we will not be unblinding the health outcomes still for a couple of months. So I can't talk about the HAPPEN trial without mentioning the fact that we have been borrowing from expertise all around the world to conduct this study. The primary PIs are Tom Clausen at Emory, Jen Peel at Colorado State, and Will Chuckley at Hopkins. Dana Barr and I co-lead the biomarker core, and Dana is located at Emory University. I'll also say that the trial is funded by the NIH and the Gates Foundation. Okay, so digging into the biomarkers a bit, our overarching goal was to characterize a wide range of the biomarkers in each of the participant groups, so pregnant woman, older adult woman, and child. For this talk, I'm going to focus here on this bolded 3rd bullet to identify, prioritize, and measure specific biomarkers of household air pollution exposure and effect in urine and dried blood spots. This 4th bullet is more in line with our biomarker discovery objective. So those are things like metabolomics and microRNA that I won't discuss in detail today, but I'm happy to chat about in the Q&A if there's interest. I also am not going to spend too much time on the first 2 bullets, but I did want to just show you kind of the very diverse settings that we were collecting biomarker samples in. And so, of course, the QA/QC checks had to be tailored to each location for us to have confidence in them. We, in addition to kind of training the local field teams and developing those QA/QC checks, we also had a goal of developing local lab capacity in our India study site. So the heavy lifting there was done by my much more analytically minded colleagues, Dana Barr at Emory University and Naveen Pudaswamy at Sri Ramachandra Institution in Chennai. As the epidemiologist part of the leadership team, I'll focus more on study design considerations. So as I hinted at earlier, this is a piece of the biomarker collection design that's taken from that much larger table I showed a few slides ago. You can see here that the 6 HAPPEN visits, these 6 HAPPEN visits plus birth incorporated biosampling. And then the table just lays out which participants. If there's an X, that means that participant had a sample collected. The pregnant woman had collections during gestation. The child had collections from birth to the 1st year of life, and then the older adult woman had collections at all 6 visits. So the actual selection of which biomarkers to measure in the urine and dried blood is fairly established for the biomarkers of exposure here. But we have intentionally built in the ability to remain flexible with many of the biomarkers of effect. So we want to evaluate markers that will allow us to say something about the various pathways that we think are important in regards to air pollution exposure. cardiovascular disease, metabolic, cancer, and respiratory endpoints. But as we've already been talking about today, we can also take advantage of the fact that many of these major chronic diseases share early mechanisms such as inflammation and oxidative stress. So one of the reasons we actually need to really focus on biomarker prioritization is that in the end of the study, we're going to have over 55,000 samples. So it isn't going to be logistically feasible to measure every analyte in every sample, of course, but we also don't think we need to do that in order to answer our study objectives. So we have a pretty good sense of the types of biomarkers that are most appropriate for each participant subgroup. So as you can see here with this table on the right, while we'll measure exposure biomarkers in all 3 of the participant groups, we've focused a marker of anemia in the pregnant woman and the child, but the glycated, the hemoglobin, the HbA1c measure in the older adult women. So that's something that's fairly well established already, even though we're maintaining some degree of flexibility. We've also spent a lot of time validating our use of dried blood spots. So if information wasn't available before we started the study in the literature, then we used formative samples to understand how well correlated dried blood spot was with venous drawn blood, for example. We also used those formative research samples to understand what we could about within versus between person variability, which also, as Ryan mentioned earlier, is really important when thinking through sample size considerations and statistical power for your study. One downside of using dried blood spots is that the sample volume can be limited. And so the prioritization comes into play more for the blood specific markers that we're interested in. So to help with that, we do plan to measure all analytes from the baseline samples to learn something about the associations between exposures and outcomes cross-sectionally, which we then hope will inform our intention to treat analysis and the longitudinal exposure response analyses with all of the repeated samples. We'll also have an analysis where we measure analytes in a 5% subsample of the trial participants. And then we'll also use this information to really help us better understand within and between person variability in those markers. And so I'll use C-reactive protein as an example of that one here in a moment. So I do want to state that while I'm sort of pointing to the factors about this study that highlight the challenges we're facing, I certainly don't want to be remiss in saying that we are also recognize that we have a pretty exciting opportunity to answer some of these research questions that have been sitting in this realm of knowledge gaps for quite some time in our field. So with that said, these next 2 slides just provide an example of how we've gone about working through prioritization of the biomarkers of in the study. So we just take a Excel spreadsheet and lay out the urine aliquots and the dried blood spots and start filling in the samples with what we think is higher priority. So for example, we know how much of the urine it takes to measure the pH metabolites we're interested in. We also have to consider our responsibility to provide some subset of our samples to the NIH's BioLink repository. We have a second tier of exposure markers and that I'm happy to talk about in the Q&A as well. And then we also have encouraged investigator-initiated proposals to add biomarkers, and this is really just our attempt to stay relevant, particularly with new papers that may have come out since we wrote the grant. So an example is Kyle Steenland's leading a study that we're doing measuring COVID-19 antibodies in dried blood spots. And similarly, Miles Kirby is leading a study associated with malaria risk in Rwanda. And so those are just some of the ways we start to fill in these tables. So this is that same sort of prioritization scheme. This one was for the child samples. This is the older adult women. So again, we have 6 repeated measures for that subgroup of the population. And here I really just wanted to point out the difference in that a lot of the literature seems to suggest that C-reactive protein, the variability in C-reactive protein seems to be driven by between person variability instead of within among healthy populations. And so if that holds to be true in our sort of initial formative analyses, then what we might be able to do with that information is to say, okay, well, we only need to measure C-reactive protein once during follow-up instead of using that first spot at every single visit. So this would allow us to answer more research questions. Okay, so my last slide to wrap up, and actually a lot of these considerations are ones that Ryan covered well already. So in my last minute, I'll move quickly through these a bit, but oftentimes when we want to choose a comparison group in a biomarker study, it's the same really with any health and outcome study. What we really want to understand is the frequency of the outcome in a group of exposed people compared to the frequency of the outcome in the same group of people at the same time if they had not been exposed. So this latter group represents what we call the counterfactual, and the absence of time machines and various movies, you know, the counterfactual is not observable. So we design studies that we believe are sort of along this continuum as far as ability to approximate the counterfactual. Happen utilized a parallel randomized controlled design. Some of the work Ryan described used the randomized crossover design, which are really great at approximating the counterfactual when the exposure of interest is shorter acting. And we also heard from John Baums with an observational study design. So next, we utilize the literature to hypothesize the time course or the speed of the anticipated exposure response mechanism that we're hoping to characterize. So again, this really is the same for biomarkers as it is for typical health endpoint studies. But the hope here is that if we're utilizing biomarkers, that we actually will be able to learn something about the impact of the exposure or the intervention, as we've been talking about a lot today, in a shorter time period compared to the need to wait for those clinical outcomes to manifest. I talked a lot about the anticipated variability in the biomarkers already. So in the interest of time, I'll go ahead and skip over that one because I think it's repeating a lot of what John and Ryan have discussed already. And I'll just add to the susceptible populations discussion with the fact that, you know, I agree with everything that Ryan had said already. And when we don't know, you know, this simplified distribution of a continuous outcome here shows the difference between baseline and post-intervention. And the idea here is that if we don't know to describe our population in terms of responders and non-responders, we might end up with just noise in our post-intervention analysis. So the idea is to really be able to characterize these. And of course, study design considerations also have to play a big role. So with that, I will go ahead and turn it over.
I need to unmute. Thank you so much, Maggie, for that presentation. And again, we have 15 minutes here for questions and discussion points from both panel and audience members. We'll have a break after that, and then we'll have our longer afternoon discussion, specifically targeting the intervention study that the program is designing. Questions for Maggie? Maybe it was just so clear that no one has follow-up questions. Jenny, go ahead.
Hi, thank you. I was waiting to see if other people want to jump in first because I thought it was so fascinating. I'm just interested in your blood spots because that's such a wonderful approach when you have to have a multi-continent study, because getting blood or serum is a real nightmare, as I'm sure you know. And I just had some practical questions. I mean, are these stable at room temperature, or are they just dried and can they be mailed? And or, you know, are they completely robust in that sense? I guess would be my question.
Jenny, as you're probably guessing, my answer is it depends. So some analytes are perfectly fine as far as degradation goes at room temperature, and there have been lots of more chemistry focused studies that have shown, how long you can leave a dried blood spot card at room temperature. Because we avoided that, and so we did end up freezing the samples after they were collected, on the sites from our local partners before getting the cards to Emory. But yes, I mean, if you're interested in particular analyte, there probably is a paper that's been written describing, and it does get more complicated as far as does it matter if you take a punch towards the end of the spot or in the middle of the spot? And so Dana Barr at Emory has been doing a lot of sort of upfront work to make sure that we can have confidence in the analytes that we're measuring in the end. One of the other big considerations is blood volume standardization with dried blood. And so that's a little tricky for us because hemoglobin is often used as a standardizing factor, and we think air pollution is associated with hemoglobin, or we're hypothesizing that it is. We want to understand if it is. And so for us, we're trying to understand if there might be other markers that would be better. And some analytes are pretty robust, I think, to that blood volume standardization issue. C-reactive protein, I think, is one, but there are some that I think we do need to be worried about that. And so potassium is an example of something we might end up using.
Thank you. So did you ship them on dry ice from these centers, or just cold?
Actually, we did not. We just shipped them in cooler boxes that were fairly well contained, but with ice packs. So we did not have the luxury of using dry ice in many of the locations. So the number of freeze-thaw cycles that various analytes are able to withstand is also typically published as part of those feasibility or validation studies, but we felt confident in that approach.
No, that's great if you don't have to use dry ice, because that's so difficult for your partners, like you're saying. So that's wonderful.
Yeah.
Thank you. So interesting.
Susan, please go ahead.
Yeah, thank you, Maggie. That was such an interesting talk. I think one of the most impressive things was you were able to continue through COVID, but I just had a specific question about the table that you showed, where you showed which biomarkers you were measuring for your various groups. And I noticed for the kids, you're measuring markers, inflammatory markers, but not oxidative stress. And I was just wondering if you could comment on how you came to that decision.
So that's a good question. And Susan, yeah, to say one line about COVID seems very inadequate, but yes, that was the ability for the teams to kind of continue that supply of the intervention, and was pretty remarkable. So I think you might be referring to the dried blood spot list, but if not, then I think I may have made a mistake, because in urine, we are measuring 8-OHGG in all the participants. So we will have that marker in the kids. But you're right. I mean, we're still, so what I would like to do is measure telomere length in the dried blood spots, but this is another issue that I think is important to think about when prioritizing biomarkers, because it's doable, and NIH is actually interested in funding studies that are looking at telomere length, and that really is because we're starting to understand that it really might be this really excellent indicator of cumulative oxidative stress. And so, but the problem with what we're doing is that it takes 2 full blood spots to do it. And so for us, that's a lot of real estate when thinking about how much sample we have. So I think, of course, we owe it to the study as a whole and to our participants that have provided these samples to think about whether or not we really can go with that biomarker as kind of that cumulative oxidative stress marker or not. But it would be really interesting to at least get to do it in a subsample.
Oh, yeah. Yeah. Okay, thanks.
Mm-hmm.
I want to check in with Shobha if there's anything from the audience, and then I see Ulrika.
Hi, I have one question passed along to me from Zwen Kaufman, and you might have mentioned this, Maggie, but were there incentives or honoraria in your programs?
So great question, and there actually is a publication on that because it was, as I'm sure the questioner is hinting at, extremely challenging to figure out what an appropriate compensation is for this type of research study. So that study is actually, the first author is Ashlyn Quinn, and it's published, and sorry, I don't have the title right here, but it's about controlled compensation for happen. There was a lot of formative work with our community groups in each of the 4 locations to figure out what we should do as far as the control groups being compensated, because in one sense, we wanted to understand the impact of the intervention itself on these outcomes that we had. We didn't want it to be the fact that there was some socioeconomic status advantage from having received the cleaner stove. And so there was some consideration of, well, let's try to match the socioeconomic potential gain throughout the 18 months. And then there was another conversation that was more like, okay, well, let's just wait. Let's not interfere with the control group at all. And let's wait until the end of the study. So the decision ended up being for us, and I'm not saying that it's right across the board, but that those control compensation, some research sites based on what their community groups were giving them feedback, gave smaller incentives throughout at each visit in the control group and a larger one at the end. And some of our countries just waited until the end for that control compensation. Hopefully that answers the question.
Ulrika.
Yeah, hi. Thank you for that really interesting and fascinating talk. My question, and you may have said something about this, is there any plan to return results to the participants? And if there is, I'm sure there's many challenges with these different cultures, with all the sites. And if you could talk a little bit about that, I think it'd be very interesting to hear about.
Thanks for that question, Ulrika. Yeah, I think you hit the nail on the head as far as this being a huge challenge. And I will say, personally, I think I've completely failed at that in the past as far as really appropriately giving results back. So it is important to think about what is meaningful in the local context for wherever you're conducting a study, right? And so I will say that the NIH has supported studies focused on the bioethics of conducting this type of work. And so we do have a supplement to work with local community groups to really figure out if what we had proposed was to just conduct a community meeting where we provide the basic results and allow opportunity for questions. But that just seems so insufficient, really, when you think about I mean, even just with the biosamples, how many samples that each person was providing. And so we are working with a couple of anthropologists on this supplement to start thinking about, with the formative early research results we had from the trial, what is most appreciated by the participants, how is it presented best. And so some of the work we've done started with exposure monitoring, the exposure results that we have for each person. And so in that context, this is extremely early analysis of the focus groups by our social scientist colleagues, but it really seems to be pointing towards kind of putting the exposure within the context of the entire trial. But then, I think sometimes the concept that there's another group that got something different than you isn't always easy to understand, because a research realm is not intuitive in all locations. And so I guess my long answer to what I really only have a short amount of information on is that we're trying to understand how to be better about that and try to make sure that we're sort of honoring the commitment that these participants make when they volunteer to be in these studies.
Thanks.
Thank you so much for that discussion. That brings us to our afternoon break. We have 15 minutes now for a break, and if folks can be back promptly, we will start right at 3:10 and move into our afternoon discussion session. So thank you so much to you, Maggie and Ryan, and who added so much to the contributions by the other speakers also, and we'll resume at 3:10.